Hyperkalemia, a potassium of 7.2, a widening QRS on the ECG, and a patient who was talking to you just 5 minutes ago. This condition kills quietly, it kills quickly, and most importantly, it kills patients who look deceptively well. In part 1, which is this video, we covered the essential foundations of hyperkalemia, and that includes the definition, the causes, the stages, the clinical presentation and the features, and how elevated potassium progressively leads to subsequent ECG changes according to the stages of hyperkalemia. I can assure you, if you get this right, then the subsequent management protocol becomes absolutely logical rather than just a tick box exercise according to the clinical guidelines. So part 2 puts all this into action that we are going to discuss today, and the part 2 will cover the assessment, investigations, and the full emergency protocol of how to manage hyperkalemia in a very nice and structured algorithmic manner. So please watch both videos and you will never be caught out by hyperkalemia again. So let's get into it. Just quickly, why does hyperkalemia even matter? In terms of epidemiology globally, it's almost 1 in 10 patients hospitalized will be affected with hyperkalemia, and it carries a very high mortality of up to 30%, which means 1 in 3 patients may die if left untreated. And it's one of the most common electrolyte abnormalities with acute kidney injuries. And incidence is occurring because of the aging population, multiple comorbidities, people with chronic kidney disease, heart failure, diabetes, etc. It's usually asymptomatic until it's critically high and leads to very non-specific symptoms. And the rate of rise matters as much as the absolute level. And the symptoms can be very non-specific like weakness, fatigue, etc. And ECG changes may be absent earlier on. By definition, hyperkalemia is when the serum potassium is higher than the normal concentration in serum. Usually the cutoff reading is 3.5 to 5.5. I mean, that's the range. Some labs have a cutoff of 5. So please look at your local guidelines, but any range above 5 is considered hyperkalemia. Mild hyperkalemia, 5 to 5.9 millimoles per liter. It's almost always asymptomatic. The key thing is stop the offending medications, restrict dietary potassium, and repeat potassium within 24 to 48 hours. Moderate, 6 to 6.4 millimoles per liter. ECG changes are highly likely at this stage. So if ECG changes are present, then you have to give calcium chloride or calcium gluconate, whichever the local protocol or scenario may be. Active treatment is almost always indicated, which means shifting the potassium with insulin dextrose intracellularly, and also as an adjunct that will be to shift, and continuous ECG monitoring may be needed. In severe hyperkalemia, which is 6.5 and above, it is usually a cardiac emergency. The first, irrespective of whether ECG changes are there or not, once you have the lab, do not wait for ECG. Immediate cardiac stabilization, cardiac membrane stabilization is needed with calcium chloride or gluconate, and the rest of the potassium shifting measures as we just discussed. You may require ICU or high dependency unit assessment for the patients in the meantime, and this may actually be needed if there is severe acidosis on top of that. The key clinical rule, please remember that first you need to assess and classify and quantify the severity. That tells you whether you have got days, hours, or minutes to act to stabilize the patient. So let's look at the potassium homeostasis in the body. Our Argentum AG dove is telling us the right balance. That's the homeostasis, how the body remains in balance despite all the odds. Around 3,500 millimoles is stored by the body, 98% being intracellular, predominantly in the muscles, liver, and the red blood cells. Hence, any of the pathologies leading to the problems with these 3 organs will lead to hyperkalemia. Only 2% is extracellular, which is maintained in the plasma and interstitium. Intracellular potassium is around 140 millimoles. Now, our daily intake usually is around 50 to 100 millimoles, depending upon the standard diet. 90 to 92% is excreted by the kidneys, while around 10% is excreted by the gut through the stools. So that's why you can imagine any impairment of renal function will have a profound effect on the potassium handling and homeostasis of the body. Also, it's secreted in the collecting duct, and aldosterone has a strong effect on that, because aldosterone leads to absorption of sodium and excretion of potassium. So that's why it's really, really crucial in handling as well. AKI on CKD due to any cause or any condition will lead to hyperkalemia, and also adequate urine output is essential to maintain this homeostatic milieu. Aldosterone we discussed, it has a hormone regulation also through angiotensin, renin-angiotensin-aldosterone system. Angiotensin 2 leads to direct vasoconstriction to raise the blood pressure, plus also release of aldosterone through the adrenal gland, which eventually leads to sodium and water retention by the body in the distal collecting duct as through the epithelial sodium channel, and leads to potassium excretion by the body. Okay, so that's why deficiency of aldosterone, like Addison's disease or type 4 renal tubular acidosis, will lead to hyperkalemia. Similarly, ACE inhibitors and angiotensin receptor blockers will have the opposing effect to aldosterone, and that's why hyperkalemia occurs as one of the mechanisms. Let's look at the three mechanisms which maintain the transcellular gradient of potassium homeostasis. So insulin is the topmost. Why do we use therapeutic insulin for hyperkalemia? Because insulin leads to the shift of potassium intracellularly. So this is important, also important for management of diabetic ketoacidosis. In addition to reducing the glucose, it also shifts the potassium intracellularly. So it drives, it activates the sodium potassium ATPase in all the cells and drives the cells from plasma into intracellularly. It acts within 15 to 30 minutes. And again, in diabetic ketoacidosis, as I said, there is a deficit of insulin which leads to acidosis and hyperkalemia both. Catecholamines, again, the beta-2 stimulation leads to potassium uptake into the cells. Adrenaline release shifts the potassium acutely, okay? So that's why the beta-2 stimulation leads to, and that's why we give the salbutamol inhaler or nebulizer in precisely in higher doses, 10 to 20 milligrams, to shift potassium intracellularly. It also acts within 30 minutes to shift the potassium. Acid-base balance, any acidosis will lead to hydrogen entering the cells, and to maintain electroneutrality, the potassium comes out. So this is the reason for acidosis leading to hyperkalemia. For every drop of 0.1 units of pH, there is a usual increase of half a millimole per liter of the potassium, rule of thumb. Alkalosis, or the opposite occurs. So it leads to hypokalemia because it drives potassium out of the cells, and hence to maintain electroneutrality, the potassium has to go in. Similarly, that's why in diabetic ketoacidosis, the same acidosis mechanism leads to hyperkalemia. And sodium bicarb, if used in therapeutic indications, that's why it controls hyperkalemia by correcting the metabolic acidosis. We need to understand the pathophysiology of hyperkalemia. Why does it occur and why does it lead to the symptoms? So for that, you need to understand in the first year, second year of medical school, when we used to study about the resting membrane potential. So the resting membrane potential depends upon the transcellular concentration of sodium and potassium. So the intracellular to extracellular potassium determines the resting membrane potential. And the sodium potassium pump, actually it maintains that particular resting membrane potential. So when extracellular potassium rises, this ratio falls, which means the resting membrane potential, or RMP, becomes now less negative, and this leads to partial depolarization. So when there is partial depolarization, membrane becomes progressively predominant. That leads to inactivation of the voltage gated sodium channels, and this leads to reduced functional sodium channels available, and hence the fast upstroke of the action potential is actually lost. This leads to slowing of the conduction depending upon whichever body organ or cells you're talking about. Hence it leads to reduced excitability, and ultimately electrical propagation fails to generate the desired effect. So this is a very important paradox, actually, especially in MRCP, USMLE and the OSCE exams. Why does mild hyperkalemia lead to progressive changes? In terms of mild hyperkalemia, initially it leads to increased membrane excitability. That's why you might get early peaked T waves with hyperkalemia. We're not talking about the toxic range. So hyperkalemia affecting acute T waves. So this is the first finding. But progressive hyperkalemia leads to reduced excitability. That actually leads to conduction failure, and hence the it's a counterintuitive point. So that leads to the other changes of prolonged QRS, prolonged PR interval, flattening of T waves, etc., and ST and T wave changes. Now, what are the implications for systems? So three main systems: cardiac, neuromuscular, and renal and metabolic. In terms of cardiac system, again, progressive hyperkalemia will lead to slowing of the conduction, especially through the AV node. I have touched upon this in my ECG module as well, and also through AV node and his Purkinje system. So this leads to, as I just said earlier, PR prolongation, QRS widening, and sine wave pattern, and eventually cardiac arrest. From neuromuscular point of view, the same mechanism with reduced excitability ultimately leads to ascending weakness, hyporeflexia, and ultimately respiratory failure if it ascends up to the involvement of the respiratory muscles like diaphragm and intercostals. From renal and metabolic point of view, again a vicious cycle occurs. So acidosis worsens hyperkalemia, and that hyperkalemia in itself leads to worsening of acidosis. So this leads to a vicious cycle when both are interconnected and both are driving each other. And our Brady turtle, so the bradycardia, Brady turtle, slow turtle tells us about the slowing of the conduction, and our AG dove, Argentum dove, was showing us a homeostatic mechanism. So in terms of causes of hyperkalemia, there are three main mechanisms: excessive intake, reduced renal excretion, and transcellular shift. Usually speaking, excessive intake will not be the sole reason unless combined with one of the other two or the combination of the two. Most of our hospitalized patients will have multiple reasons. Potassium is a sole reason in terms of dietary intake, unlikely. However, high potassium diet like bananas, oranges, orange juice, dried fruits, nuts, packed crisps, these are high sources of potassium. Similarly, IV or oral supplementation in hospital can be one of the reasons. Blood transfusion, because the stored blood will have hemolysis, which can lead to a breakdown of blood cells, and hence potassium is released. Salt substitutes: instead of sodium chloride, some people use potassium chloride, which is called low salt because it has lower sodium content, because they want to avoid hypertension. Then coming to the next category, which is the reduced renal excretion. One of the most important causes of hyperkalemia. It's a crucial slide. We have touched on a lot of these factors before. So if you look at, you will have three main pathophysiological reasons. One is the intrinsic renal disease itself, adrenal associated hyperkalemia, and drug induced, which is very common again. Intrinsic renal, it could be acute kidney injury, which is a very common cause. It could be chronic kidney disease due to any reason, which leads to reduced nephron mass and eventually the potassium handling by the kidneys, which should be in a normal situation 90 to 95% of the filtered potassium or the absorbed potassium should be excreted by the kidneys or handled by the kidneys. So when the CKD is progressing to stage 4 and 5 and the eGFR falls sort of 30 to 45 ml per minute, this risk becomes greater, and hence the oral intake becomes even more significant in this situation. eGFR less than 30, there is a very high risk of hyperkalemia. Again, dialysis patients, especially the ones who are oliguric or aniuric, not passing any urine, so they in them the periodic dialysis every 3 days is the main reason of clearing the toxins, including electrolyte adjustment. In those patients, interdialytic oral intake of potassium is really crucial. So now the intake really matters here. Adrenal insufficiency, we have discussed. Anything which leads to reduced aldosterone level, whether it's primary, whether it's Addison's disease, whether it is secondary due to pituitary deficiency, or type 4 renal tubular acidosis, which is hyporeninemic hypoaldosteronism. All of them are very common in diabetic nephropathy. And in such patients, sodium level can also give you an idea. So low sodium, high potassium with hypotension, always check random serum cortisol to exclude adrenal insufficiency. Drug-induced, extremely common: ACE inhibitors, angiotensin receptor blockers, calcineurin inhibitors, non-steroidals, potassium-sparing diuretics. Septrin, trimethoprim sulfamethoxazole, it blocks the epithelial sodium channel in the collecting duct, and that leads to reduced clearance or excretion of potassium, and that leads to hyperkalemia as well. Third mechanism is the transcellular shift, just linked with our previous discussion that we had in terms of the homeostasis and physiology. The same applies to pathophysiology now. So anything which affects the transcellular shift of sodium or potassium, especially potassium shift, which can lead to hyperkalemia. So basically, as we said, 98% of the body potassium is intracellular. So this shift can have a meaningful impact on the circulating potassium concentration in the blood. What is the mechanism? So hyperkalemia, when the potassium exits the cells, it leads to raised plasma potassium. That can lead to all the changes in the different tissues, including cardiac, and that can lead to cardiac a risk of arrhythmias and eventually cardiac arrest. Metabolic acidosis, one arm, we discussed before. So potassium and hydrogen and potassium, they work in opposite directions. So when hydrogen moves in, potassium moves out. So to maintain electron neutrality, that can lead to hyperkalemia. Cell lysis syndrome, whenever the cells break down, whether it's muscles and rhabdomyolysis and tumor lysis syndrome, and the tumor starts breaking, red blood cell lysis due to any reason, salbutamol, salmeterol, these nebulizers, they shift potassium because these are beta-2 stimulants, so they shift potassiums intracellularly, while beta blockers on the converse will lead to hyperkalemia and its opposite action. Other causes like neuromuscular blockers, for example, the drugs given by general anesthetic, succinylcholine, hyperosmolality, digoxin toxicity. Pseudohyperkalemia, very, very common, or should I say it's not uncommon at all. You should always consider it first if the patient is asymptomatic, no other risk factors. Number one, hemolysis in the sample can occur due to prolonged transit time using small needles, small venflon, small sized, and hence there is hemolysis in sample collection. Prolonged tourniquet application can lead to direct ischemia and release of the potassium from muscles and tissues and fist clenching, etc. Similarly, extreme thrombocytosis or very high white blood cell count, that can lead to spurious rise due to the breakdown of platelets and white blood cells, releasing the potassium from cells into the sample itself. What's the solution? Check the plasma potassium rather than serum, which can give us a correct reading. Coming to the clinical presentation for hyperkalemia, how do the patients present? Neuromuscular, then ascending paralysis and cardiac symptoms. Neuromuscular, so again you have to relate with the pathophysiology, physiology, cardiac membrane, and the resting membrane potential, action potential, etc. we discussed in the initial slides. Neuromuscular, coming to the muscular, it could be generalized muscle weakness, fatigue, tiredness, inability to rise from the chairs. The proximal muscles are affected more. It's more of a proximal myopathy than the distal. Lower limbs are affected first because it's more of an ascending pattern. The patient can be just non-specifically unwell, fatigue, malaise, muscle cramps. Then it could be paresthesia due to the neuronal involvement as well. In terms of ascending paralysis, as I said, it's flexed weakness spreading upwards. Ascending paralysis from lower legs upwards and areflexia, hypotonia due to severe hyperkalemia. Again, why? Because the membrane potential is affected and the action potential is impaired. The higher it goes, the more the risks of ascending paralysis affecting the diaphragmatic muscles and intercostals, which can lead to respiratory arrest as well. That usually occurs in very critically high potassium levels of above 7. Same as dysphagia. If the bulbar muscles are involved, it can lead to dysphagia. In terms of cardiac symptoms, the symptoms could be palpitations due to the ectopic beats or arrhythmias. It could be bradycardia. So remember our tachy beetle indicates the palpitations and tachyarrhythmias. And our brady turtle, the green turtle, indicates the slowness of the bradycardia. Chest discomfort, if there is hemodynamic compromise, that can lead to ischemia and discomfort. Syncopal, pre-syncopal symptoms as well, same due to the brain's hyperperfusion. And eventually, cardiac arrest may be the sole presentation in such patients with critically high level of potassium. Gastrointestinal symptoms, I don't think they're very reliable. The patients can present with the cause or the consequences of hyperkalemia. Usually, if it's diarrhea, vomiting, nausea, abdominal cramps, it could indicate the volume depletion and hence it could be the cause of hyperkalemia. But also hyperkalemia can lead to all these symptoms because of the poor motility in the GI tract, etc. The key clinical role in such situations is to never rely on symptoms, and you need to exclude hyperkalemia along with other metabolic abnormalities. Cardiac arrest can be the only and the first sign. Always check potassium in any unwell patient. Usually we do a quick venous blood gas before the labs are done, so the VBG can give you a wealth of information instantly. Acid-base balance, sodium, potassium, hemoglobin. You can't rely on oxygenation for that, but at least from acid-base point of view, you can have extreme information, lactate, bicarbonate, their perfusion status. So VBG can be one of the most crucial bedside investigations. ECG is mandatory in patients with high potassium, especially above 6. And that's really, really crucial. Below 6, it depends upon the rest of the risk factors as well. And again, repeating potassium and monitoring it frequently is one of the key things. So these next two slides are actually a summary of what we have discussed in the clinical presentation, but in a very nice flow chart. Neuromuscular features and cardiac features with different levels of potassium. In neuromuscular, when it's mild hyperkalemia, 5 to 5.9, in some labs 5.5 to 5.9. Usually it's vague, generalized fatigue, proximal muscle weakness, inability to, climb stairs, etc., etc. The deep tendon reflexes will usually be intact. In moderate, 6 to 6.4, the lower limb weakness will be prominent, especially proximally. Areflexia starts to begin, which was hyperreflexia before, and eventually the patient will be unable to rise even from the chair. Previously, they were able to climb stairs with difficulty. In severe hyperkalemia, which is 6.5 to 7 millimoles per liter, you will have ascending flaccid paralysis. Dysphagia is a possibility because of the involvement of the bulbar muscles as well. And paralysis can lead to upper limbs now rather than lower limbs. Above 7, the respiratory failure can be a very strong reason because of the diaphragmatic failure and intercostal muscle failure, and hence come almost near total areflexia everywhere. When obviously such situation occurs, you need to think about, or even before that, you have to think about ICU or HTU involvement. Breathlessness in a patient with hyperkalemia is a pre-terminal sign. This really means their ventilatory drive, their oxygenation, and their respiratory muscles are getting affected. So they will start developing retaining CO2 and developing hypoxia, which is a critical life-threatening event. So it has to be prevented in all fairness. But if it does show up, that means the time is running out. You need to act very, very quickly. As for the cardiac manifestations, depends upon the level of potassium. So in early cases of potassium between 5 and 6, there could be sinus bradycardia manifested by our bradyturtle because of the slowing of the SA nodal automaticity, because it's an automatic node, so that will be impaired. The PR interval starts to prolong. Sinus bradycardia can occur 50 to 60, and the PET T waves are already present. We discussed in early phase, you may have hyperexcitability leading to tall T waves. In terms of the 6 to 6.5, when there is moderate hyperkalemia, again, now before you had the first degree heart block, now you're talking about the AV blocks. Conduction slowing predominantly affecting more sort of the lower parts of the conduction system, and you will have prolonged PR. Previously we had the sinus brady, now it's prolonged PR interval. Then you will have risk of progression to higher blocks, so that the bundle of Hayes and Purkinje system are now affected, bundle branches, and then Purkinje system can be affected. Similarly, 6.5 to 7.5, it's a critically or severe hyperkalemia that can lead to ventricular arrhythmias, ventricular tachycardia, broadening of the QRS. So the lower in the conduction system it goes, the higher the degree of the block itself, and that can lead to ventricular patterns of rhythm origin, and right and left bundle branch blocks can occur, bizarre morphology, sustained ventricular tachycardia. Again, intravenous calcium chloride or calcium gluconate, anything above 6, and if you're worried above 6.5, you're worried, you have to give it even without checking ECG. Above 6 with ECG changes, below 6 with ECG changes. It all depends upon patient's hemodynamic situation, presentation, and the risk factors associated with it. But above 6.5, I think you can safely give calcium unless you're suspecting digoxin toxicity. In that situation, you have to be very, very careful. But you have to protect the cardiac membrane. We'll come to the management in our next video. Above 7.5, it's very high risk for developing the sine wave pattern and sudden cardiac arrest risk, and hence that situation should be avoided. However, if it occurs, then it's a real cardiac arrest situation, peri-arrest arrhythmias. You have to think about activating code blue or 999, whatever the case may be. If it's peri-arrest arrhythmia, again, it needs to be dealt with in the same manner. We'll come to the resuscitation and stabilization in our next video.